Thank you. Our next presentation is Fractyl Health, and I'd like to welcome Timothy Kiefer, Chief Scientific Officer, to the stage.
All right, thank you very much for attending. So I'm going to tell you now about what we think of as a one-and-done GLP-1 gene therapy for the treatment of diabetes and obesity. It's my disclosure. So I think you're probably all aware of the wonderful, profound effects that GLP-1 can have on body weight loss and improving metabolism. But it's also becoming apparent that high discontinuation rates result in rapid weight regain and the loss of those metabolic benefits. So achieving weight maintenance is becoming increasingly a critical challenge that we need to address. Now, people stop taking GLP-1s for a variety of reasons, and these recent data from Blue Cross Blue Shield show that about 30% stop taking GLP-1s within the first month, and that increases to about 50% within the first 3 months that discontinue. So at Fractyl, we're working on a GLP-1 gene therapy approach. We're targeting the pancreatic islets for durable meal-regulated expression of GLP-1. So you can see our vector is AAV9, and the payload is an insulin promoter driving the coding sequence for GLP-1. That means the expression is restricted to the pancreatic beta cells. And we've selected the beta cells specifically to harness their ability to secrete a protein in a meal-dependent or glucose-dependent manner. So that GLP-1 that's released from the beta cells can act locally on the pancreatic islets and have all those wonderful trophic effects on the beta cell. But it can also, like insulin, be secreted and have all the other complementary effects throughout the body. So I'll start by showing you some in vitro data of AAV delivery of genes to the pancreatic islet. So on the left here, you see islets transduced with AAV9 expressing green fluorescent proteins. So you can see widespread expression throughout the islets. And on the middle, when instead of a GFP sequence, we have a GLP-1 coding sequence, you can see that we can improve glucose-stimulated insulin secretion from those human islets, consistent with the well-described effects of GLP-1. We know this is mediated by the GLP-1 receptor because, as shown on the right, we can block that with the GLP receptor antagonist, Exendin 9-39. So how do we plan to implement this in a clinical setting? So have developed an endoscopic delivery approach, which consists of ultrasound-guided endoscopy with a needle injection through the stomach wall directly into the pancreas. So this is a local delivery, so that enables, obviously, limited systemic delivery, reduced cost of goods. And as noted in the bottom, the procedural risk is really minimized by the delivery approach and adjustments we've made to the design of the needle. Having said that, this is a fairly routine procedure with about 300,000 ultrasound-guided endoscopy procedures accessing the pancreas per year in the US. So we've optimized this procedure, as I mentioned, and our model has been the Yucatan pig, similar size and anatomy of the pancreas to humans. You can see here the expression of green fluorescent protein driven by a promiscuous promoter, just to show how widespread the expression is throughout the pancreas following a single injection. And then quantified in the green bar graphs, you can see the percent of expression of GFP in the endocrine cells reaching as high as 40% with a relatively low administration of virus. We've done this in more than 80 animals now and have seen no adverse safety signals specifically looking for pancreatitis. So what about the therapeutic efficacy? So we started in the DB mouse model. This is a mouse that has a mutation in the leptin receptor causing profound diabetes and obesity, and it's commonly used in the field to study the efficacy of GLP-1 based therapies. So our model here is to give a single injection, in this case IP, in the mice of the AAV with the insulin promoter driving our GLP receptor agonist. And as a control, we give the animals daily semaglutide and track the results in terms of glucose homeostasis and, as I'll show you, also body weight. So first, looking at blood glucose, on the left, you can see the well-characterized effect of semaglutide in blue, the glucose-lowering effect of that daily administration of the GLP-1. And you can see the single injection of the virus was more potent in lowering blood sugar. That's the red bar graph. Commensurate with that, in the middle, you can see the increase in insulin as expected with semaglutide, and yet a greater increase in insulin with the single injection of the virus. And somewhat surprising to us, in this model where semaglutide did not change body weight, we actually saw a significant reduction in body weight following that single administration of the GLP-1 receptor agonist expressing virus. Now, at 9 weeks post-treatment, we isolated the pancreatic islets, and we're delighted to see that the GLP receptor agonist is released from those islets in a glucose-dependent manner. So you can see it increases from 2.8 millimolar glucose to 16.7. So this is an acute meal-dependent release of the GLP receptor agonist coming from the pancreatic islets. You can see in the middle they have a very high content of the GLP-1, and so when we express the release as a percentage of the total cell content, it's really small, meaning the cells are just releasing 1 or 2%, and they have a high secretory reserve of the GLP receptor agonist. We also looked at insulin, and we're happy to see that the ability of the islet to release insulin was improved when the islets were also getting exposed to the GLP-1. So you can see in panel A, they release more insulin in response to glucose, and in panel B, they have a greater insulin content. And again, that's fitting with the role of GLP-1 to improve beta cell health and promote insulin biosynthesis. Just like GLP-1, they only release a few % of that content in response to the glucose challenge. Now, given that we had seen that intriguing body weight loss in the DB-DB model of diabetes, we decided to transition to a high-fat fed mouse model, which is more a model of obesity. And so we did the same kind of study. We gave a single administration of the virus compared to daily semaglutide. But at day 29, like many who will lose their health care coverage for GLP-1, we stopped the GLP-1 injections of the animals. Half of them were just left for a washout period, and half of them got a half dose of the GLP-1 virus. So we can compare the GLP-1 given at the start of the study versus post-weight loss on a GLP receptor agonist. So here's the first month or so, controls in gray, the daily semaglutide injections in blue, and you can see that well-characterized response, profound weight loss. And you can see with the single virus injection, we even got more weight loss for that first 30 days. Following the washout, you can see the rapid regain in body weight in the blue group. And again, that's similar to what happens in humans when they stop taking the drug. But we were happy to see that when we gave those animals, after losing weight on the GLP receptor agonist injections, a half dose of the virus, they were able to maintain that weight that they had lost from the GLP injections. So at the end of this study, you can see the blue group had bounced back up to essentially their same starting weight, whereas we were around 22 to 25% body weight in the two groups that got the virus. Not surprisingly, the food intake is as expected, and I'll just draw your attention to the sema-withdrawal group, those open circles. And you can see after stopping the GLP-1 injections, their food intake doubled for a period until they regained the lost weight. So where's that body weight loss coming from? You can see in panel A the absolute values of body weight. Again, this is at the end of the study, so the semaglutide-treated animals have regained their body weight. And you can see there's a relative sparing of lean mass, with most of the mass that's lost coming from fat mass. And fitting with that, you see the adipocyte-derived hormone leptin is significantly reduced with the gene therapy, whereas it's bounced back up to the control levels after withdrawal of semaglutide. What about glucose homeostasis in this model? So first at 4 weeks, so the animals are still on the semaglutide. You can see both the semaglutide and the gene therapy significantly reduced blood glucose levels. And in this model, when you lose weight, you improve insulin sensitivity. There's less demand on the beta cell. So you can see insulin levels drop with both sema and the gene therapy. But when we go to 8 weeks, you can see the glycemia has bounced back up after sema withdrawal. The insulin has bounced back up, but we see sustained durable effects on glucose lowering and improved health of the beta cell with lower insulin output. So this importantly means that with this system, the beta cells can adapt over the long term, commensurate with the demand for insulin related to insulin sensitivity. We looked at the pancreas to see if there was any pathology, and basically to summarize, we didn't see any difference between the groups, meaning that treatment with this virus into the pancreas isn't causing an immune infiltrate to the pancreatic beta cells, producing that normal wild-type GLP-1. So in conclusions then, we feel our early safety and feasibility observations in both the DB mouse model, the diet-induced mouse model, and the Yucatan pigs is encouraging. This is the first demonstration of nutrient-responsive GLP-1 secretion in islets. We think that's important because it mimics the normal physiological production of GLP-1 coming from gut enteroendocrine cells. It's normally released during a meal, and then levels return to basal, and we feel we can mimic this physiology with GLP-1 coming from the islet. It improves fasting glucose and insulin in these models of type 2 diabetes and obesity, and leads to durable weight loss, whether given at the start or after weight loss with the GLP injections of semaglutide. And so based on these encouraging data, we're proceeding with IND-enabling studies, and we're really keen to get this into the clinic soon. So with that, I'll thank you all for attending and welcome any questions. Yeah, go ahead.
So this is AAV, right?
Yes, AAV9.
So I think it is in the context of all the other AAV therapies out there, especially like for, rare diseases or oncology and so forth. So if someone were to get this, they wouldn't be eligible for any other AAV therapies? Have you thought about that?
Yeah, so first of all, thank you for that question. So I'll first say that we're somewhat agnostic to the vector, right? We chose AAV9 because it's clinically approved. It's used, for example, with Zolgensma. We feel we'll be using orders of magnitude less by virtue of the direct injection of the pancreas. And it's something I think we all need to consider in this field. If someone's a recipient of one therapy that's AAV-based with a certain serotype, that may make them ineligible for a different therapy with the same serotype. So, I agree that's an important consideration, but again, I think we're open to the possibility of using other serotypes. We found other serotypes that actually work better for the pancreatic islet. We're also considering non-viral approaches, and it remains to be determined with a low local dose directly into the pancreas what type of immune response we'll get and how that persists. So we'll have to address that in future studies.
Like lipid nanoparticles potentially, would the technology be deliverable that way?
Yeah, we're considering that as one example, for sure.
Very fascinating, great work, thank you.
Thank you for the comment. Yes.
Great talk, thank you so much. It's really promising that you're able to show improvement in fasting glucose and insulin. I'm curious, were you able to show an improvement in the functional response postprandial?
So if I heard correctly, your question is, did we see an enhancement of a functional response from the pancreatic islet? Yeah, absolutely. It's really remarkable. And I'll say that even the tech who was isolating the islets from the DB mice noticed, she could tell whether it was the control group or the virus, because normally the DB mouse islets are very fragile, unhealthy. They've been exposed to high glucose and lipid, and she said that the DB islets that had the GLP virus were much more robust, easier to isolate. And indeed, when we do that, we see improved glucose-stimulated insulin secretion coming from those islets. So there's no question that the local production in the islet is improving their function. Yeah. So we believe, based on that, that a very small local amount within the islet will be all we need to really have a marked effect in patients with diabetes. We don't need to expose to the very high levels that lead to nausea and vomiting, for example, that a lot of patients experience. Thank you. No further questions? Thank you very much.